topic for today is a really interesting one. We've called it Beyond Engagement, Strategic Approaches to Consumer and Community Engagement. We'll be talking with experts who have gone beyond engagement, I would suggest, to lead to mature, innovative and evidence-informed approaches to asking consumers and communities what they want from primary care. So moving into our conversation, it might have passed us all by, but did you know that we've got a new World Health Organization Social Participation in Universal Healthcare Declaration? It recognises that lived experience and knowledge shapes better policy, more inclusive health systems, improved services and experiences and outcomes. And I think that's knowledge that our experts on this call already know and will be talking more about. But it also recognises that while people are increasingly being engaged as partners in health systems, that recognition and that influence and the practice of consumer and community engagement is very, very variable. But most importantly, the resolution makes social participation a core function within health systems, not something that's an ad hoc add-on. And it commits countries to strengthening, systematising and sustaining social participation. Writing about the declaration, a Canadian patient advocate who may well be known to all of you, Vincent Dumaze and colleagues in a BMJ article summed the declaration up well, I thought, when they said, let's amplify people's voices by connecting the grassroots to the treetops.
What a great quote from that consumer advocate. I think the idea that we have top-down is really important. Top-down is a as it calls itself, a declaration of intent. But of course, without the bottom-up, you don't have anything at all because the top can't make it happen. And we've seen this in the national standards for Australian hospitals, for example, where you have a standard which says you will partner with consumers. The intent is very similar. But I think that it's an opportunity for the intent of the WHO to be used as a lever by people in the field who need to say, well, look, we have to align with these best practice intentions of a reliable and trustworthy organisation like the WHO. So I really welcome it, Leanne. I think it's a great statement. But I agree with Vincent that you really do have to join the bottom to the top to make it happen. And that's really what we're talking about today.
Firstly, I think it validates and reinforces health as a human right. And we're talking about a global community here, right? So really, really important to have that. And I think in stating what it states, it's fundamentally reinforcing the importance of trust in health systems. And really the only way we can achieve that trust in health systems is through that participatory, active involvement of the community. Health is about delivering public value, and you can't deliver public value without involving the public. And I think that's what the declaration says. Of course, where it makes a difference is where the rubber hits the road, and that's kind of reinforcing that BMJ article quote you mentioned earlier.
Tara, can I start with you? You spearheaded the Our Care initiative in Canada, where you heard from thousands, I think it was, of people about what they wanted from the primary care system. But it seems to me you took quite an innovative, progressive, genuine deep dive community engagement approach to that. Can you tell us about the approach you took to Our Care?
Yeah, absolutely. And I should just, contextualize it by saying the primary care system in Canada, I think, is widely regarded as being in crisis right now, with more than 6.5 million people without actually access to primary care. And we know reforms are needed. And the reason we started Our Care is because we wanted to bring that public voice into the discussion of what these reforms should look like. What should the vision of primary care be like moving forward? and what are the pain points and what are the priorities that the public have. And so we launched Our Care back in 2022. It had 3 phases all in all. The first phase was a national survey where we heard from just over 9,000 people across the country. And the survey really took the pulse of what was happening across the country, what were people's experiences, but also what were their preferences for care. For example, we would give them ideas of how we might be able to change the system, and wanted to understand, their willingness, for example, to see a nurse practitioner instead of a family doctor for most things. And people responded and told us what it was that was important to them. But I think the really unique aspects of Our Care are actually in the second and third phases that we conducted. So our second phase were a series of 5 priority panels. These are another word for these priority panels might be a citizens reference group, I think similar to what we're probably going to hear from Coralie. So what we did is in each of 5 provinces across the country, and in Canada we have 10 provinces and 13 territories, so we did 5 provinces across the country. And in each one we assembled a group of 36 randomly selected residents of the province. And they were randomly selected to roughly represent the demographics of the province. And we brought them together for between 30 to 40 hours, where they spent a lot of time learning about the primary care system from experts, but then they also spent a lot of time in small groups deliberating about what are the values that should underlie the system, what are the top issues they wanted to see addressed, and then, of course, what the recommendations for better would be. And each panel actually wrote their own report, and also at the end of those 30, 40 hours presented their results to key decision makers at the provincial level. And I should say in Canada, for context, healthcare decisions and delivery are really actually done provincially. So this was important to actually engage our provincial decision makers. And each panel was also guided by an advisory group based on stakeholders from that province. So we conducted these 5 provincial priority panels, and at the end had these 5 reports from each of the panels. And then the last phase, the third phase, was really actually designed to amplify voices we thought we probably missed in the first and second phases. We really tried hard actually to have diversity in the first and second phases, but we knew that the process itself of conducting, of doing an online survey or being involved in something for 30 to 40 hours probably excluded people. And so in the third phase, we conducted 10 community roundtables, 2 in each of the 5 provinces. We partnered with community organizations that had established relationships with members of marginalized communities. And so our community roundtables, had different foci. Some focused on newcomer health issues, some on people who are Black, people who are Indigenous, groups that we know are more likely to suffer from unequal health access and worse health outcomes. And so those community roundtables, built on what we had heard in the first and second phases, but provided important nuance that was really relevant to those groups. And then we summarized all we heard in something in our final report, and we put forward something that we called the Our Care Standard, which is 6 simple statements that really define what every person in Canada should be able to expect from the primary care system. And they really summarize what we heard from the, nearly 10,000 people we engaged with over the 16 months. And I'll tell you more about it, but, those statements have actually garnered a lot of traction from our policymakers and are starting to be taken up as really the direction that we need to go when we're thinking about reform in our country.
When we think about the context of where we are in primary care in Australia, we've got access issues. We don't actually know how many people don't access a GP because we don't have a registration system. But what we do know is about 20% delay accessing a GP because of cost. It's not dissimilar to Canada, I don't think. We've got workforce shortage issues. We've got 10% of GPs age 70 or over. We've only got 15% of medical students choosing general practice as a career, as opposed to 50%, a few decades ago. We've got healthcare costs rising, out-of-pocket costs for consumers are increasing, and that's, I think, compounding the equity issues that were there already. We've got fragmentation of care, and in Australia we seem to talk about fragmentation, within the health systems of primary, tertiary care, allied health services. But actually, when you think about social care, we've got even greater fragmentation. Other countries, the conversation around integration is health and social. We still talk about integration in health alone. We haven't really gone broader than that. And then we've got all the technical issues and digital health and, the issues around that. So when we're thinking about context and the problem and the challenges within the health system, they're absolutely similar to Canada. They're growing and they're significant.
We're trying to model all of the conversations around those recommendations. So my job, month to month, is to speak to people who want to talk to us. So I guess we use a cool club model where if we can show the rest of Western Sydney that this conversation is really connected, that we're connecting into people who are already doing good work but are not known to the general population. So how do we forge alliances where the people are at the centre of that alliance, not peripheral? But those people are actually the driving force, if you like. The well-informed voices of the people are the driving force behind why should we do this? Because it's the why that is the motivator for everybody, for healthcare professionals, for policymakers, for politicians. If they have this voice of the people that's saying, this is why you need to do this, then there's more motivation. And then if you can see it working, I would like to think that in 5 years' time, we're looking at this is a method of keeping those recommendations at the front and in the centre, but driven by the people who understand the background, the context.
I think what I'd really love to see is a process report which kind of talks to the multifaceted strategy we've heard about. The our care type of approach and report, looking at macro and be able to report on that. Coralie, the sort of examples you describe in the citizens' juries and hearing the voices of society, but replicated across a number of PHNs will be a really lovely process measure to report. Beginning to pilot in general practices incentives that have patient participation groups or critical friends groups that are doing similar things, beginning to feed that up. And the learnings from that is something I'd really love to report in 5 years' time. So that's process stuff. What would be nice is to be able to report some outcomes, examples of how policy has shifted, how our 10-year primary care reforms pivoted because of the voices it's heard through those processes. And that would be just wonderful to report. I actually think that's realistic. I think it's achievable. It's obviously time bound. It's measurable, and it's pretty specific. So it kind of meets that SMART goal, SMART aim approach. What we really need is the will of policymakers to support it, to make it happen. So that's what I'd really love to see in the imminent future, probably after our general election.
Thanks very much to all three panelists. So I'm so uplifted, I'd have to say, by the conversation. And I think it's a truism, isn't it, that health systems are constantly striving for improvement. And I think it's the case, the same case applies to consumer and community involvement and thinking about that and embracing that as a core function of health systems. Are we there yet with that sentiment? Probably not. And Tara, you talked about it needing a cultural shift. You've both spoken about that, Coralie and Tara, and then Paresh talked about the levels within systems, macro, micro, and meso. It's not just enough to have consumer and community involvement at one level. We need it at all levels in the system.